Okay. Be careful what I say now, right?
Well, so I don't know, unless someone is actually on our YouTube channel, I don't think you can see it. Although it says there's 10 viewers, so I don't know what that means. But
so is there anything I'm supposed to do on my end? I've not received another email, so.
You haven't received it from SwapCard?
Nope.
Yeah, I don't know.
The only link I got from was for this. There was no other link contained in that email that I could see.
Oh, it's because it's disabled. Well, that would be why. Okay, so let me.
Hi, Mark. How are you?
Hi, good, Julia. How are you?
Good. You have your voice memo set up?
I've got it ready to go. I haven't turned it on yet.
Great.
Remind me to do it just before we start so I don't forget.
Okay, will do.
Oh, you chose the background I thought of using. I'm going with my office instead.
Okay.
Okay, so Julia and Mark, there should be an email coming through for SwapCard for you guys to be able to log into SwapCard so you can interact with the attendees, because the attendees are not going to be on Zoom.
Okay.
Are they using another?
They're using SwapCard.
Okay.
So it is planned to send out at 3:55. So you should be able to get. It's kind of weird that I can't have the dates be in the past, but.
All right, I'm keeping an eye on my email right now.
Oh my gosh. Or maybe I can change it to. Oh no, that's fine. Yeah, it'll be.
I don't have an email from SwapCard.
Yeah, it's coming. It will be coming anyway.
And what are the what does this do?
SwapCard is a conference platform so that it allows for a more interactive experience for attendees with each other and also with the speakers. And it also we're mostly using it for obviously the AI conference in a few weeks, but so it's not as useful for today, but it'll be cool because you can actually interact and chat with the attendees, and they'll be able to put their questions through SwapCard. So they will see a video feed of Zoom in SwapCard via YouTube. So right now you can see, if you look, you can see that we're streaming right now.
Yeah.
So that's going to YouTube, and then SwapCard grabs that feed. So there's a little bit of, I think they said there could be up to a 20-second delay between what we see here and what they see, but we don't know. We don't know actually what that exact lag time is.
And this is open to like a secure group, right? Because normally things are. Okay.
It's only open
Members.
to people who registered through Eventbrite. So SwapCard is linked to our Eventbrite registration. Yes.
So they've been sent SwapCard links as opposed to Zoom.
They
links.
have, yes. And we have over 20 something people.
Great.
Great attendance.
So it'll be really great.
Surprised, it's still the work day. I mean, I literally just got off. I'm back to back today, so had to
Oh, wow.
jump off a call, and then we'll have to get on a call again right at 5 o'clock.
Oh, wow. Yeah, you are back to back.
Yeah, and my podcast equipment isn't working, so I think I'll just do what you're doing, Mark, and I'll be using my voice memo as well.
Okay. I just got something from, just says MIT COVID-19 Front Line. Is that what you're looking for?
Yes.
Okay. Hold on a second.
And Julia, you should have also received the same thing. I'm hoping.
Yeah, so I just say access my profile.
Yes. Mm-hmm. And with this, with SwapCard, it will automatically go live at 4 o'clock. So people will be able to see this video feed at 4 o'clock.
Do I have to create a password?
You can, it'll be your own password, whatever you want it to do, that you'll be able to use for SwapCard going forward.
But it'll just, I don't need to, right? It'll just automatically do what it's doing.
Well, you need to set up a profile. I guess you need to just log in. So I think you can set up like your own password, or I think there's something about like a magic link option.
I think I'm in now.
Okay.
So if
Yep.
you're on the home page, you see on the top, there's like home, attendee, speaker.
Yeah.
Watch
So
live
should I just
session.
use this instead of Zoom?
Yes, yes. Well, in terms of visual, you'll use Zoom, but interaction is SwapCard.
And I can mute myself?
No, you don't want to mute yourself because you'll just be seeing what's happening on SwapCard in terms of people chatting.
Yeah.
So apparently there's already one long question from Keith asking a question for Dr. DuLong.
Okay. Well, we're going to save the questions at the
For
end.
later. Yeah.
And we'll also be choosing the questions.
Yes.
Right.
Yes. Absolutely. Yes. Everything in terms of how you manage the event remains the same. Nothing changes.
I just need an extra window up.
Yes. Yes. For a SwapCard.
All right. So am I best off on Zoom or SwapCard? Do you care?
You should use Zoom when you're interacting with Julia because that's going to be the live feed. That's going to be the most current because there is that lag on SwapCard, and we don't know exactly what that lag is yet.
All right. Okay, perfect.
All right. Are we guinea pigs of SwapCard?
Sounds like it.
We tried
just
doing
come
it.
out?
We tried it last week on a Friday event, but the emails weren't working. So this is actually the biggest live test.
Are any of those stuffed animals behind you guinea pigs by chance?
Well, they're guinea beavers.
Guinea beavers, okay.
Yeah.
Should I turn on my voice memo now?
Yes, let's do that. And I'll turn mine on too.
And I will, I'll turn everything off on my end, but I will be around in case you guys have any questions that you I need to pop back in.
Thank you. Hello, everybody who's joining in. We'll just get started in a minute. Okay. All right, Mark, how are we doing?
I'm good, ready to go.
All right, good. I just need one more second to get my equipment here set up. All right. Thank you, everybody, for tuning in to MIT Club of Northern California's COVID-19 Frontline series. We are delighted here to have our special guest speaker, Mark DuLong. If you recognize Mark's name, he was on episode 9 of our MIT Catalyst podcast. And when we last spoke, this was beginning of April, so almost 3 months ago. And as we know, in the past 11, 12 weeks, our world has changed a lot. So thank you so much for being here with us, Mark.
Oh, thank you very much, Julia. Thanks for having me back. It was interesting when I first agreed to do this, things looked very different than they do just a few weeks later. So I think we have a lot we could potentially talk about today.
Fantastic, and we're delighted to have you. So for those on the line, could you just give us a quick introduction, including what year you were at MIT, what you studied, and what your current role is today?
Sure. So I graduated from MIT, the class of 1982. I got degrees in computer science, biology, and mathematics. So 6, 3, 7, and 18. I think that's what everybody understands at MIT. And my goal when I was at MIT was actually to get a broad education, which I really did, because I wasn't really sure which direction I wanted to go, but ultimately decided on medicine, and no regrets looking back. So completed medicine in 1986 at Brown, and then I came out to California to go do my plastic surgery residency at Stanford. I completed that in 1992, and I've been at Kaiser Permanente in Santa Clara since that time. So my clinical profession is plastic surgery, and I've been doing that for the last 28 years now, I guess. But on top of that, I've expanded into leadership roles over the course of my career here. And that's been actually the biggest part of my contribution to our response to what's going on right now.
And Mark, could you just tell us how many degrees you have again from MIT?
3.
3, wow, okay.
Yeah.
I barely got through having 1, so that is, we know that's a triple accomplishment right there.
Thank you.
Wonderful. So how is the morale right now? We're several months in, and it looks like there's not an end in sight. How are you feeling, and how is the practice feeling?
A lot of mixed feelings. I don't think there's a single word that could describe it, and I would say it even changes over time. I think when this all started back in March, my medical center was one of the hotspots in the country. Washington State and then actually Santa Clara County were the early hotspots. So it was an interesting place to be. There was so little known about the disease at that time, and there was so much controversy about how we should respond, what we should do. And so to be at the forefront of that was both exciting as well as in some ways kind of terrifying. It was an awesome responsibility to try to help navigate which direction to go when there really wasn't a lot of clear direction. Not many people really knew what was the right thing to do. So for me, again, created a lot of anxiety, but it also created a real sense of purpose for me, that I knew that I actually, in my leadership role in particular, I had a lot that I could contribute here. So the more that I could learn, the more that I could communicate to those who relied on me for information, the more successful we were likely to be as we navigated through that. But a lot of uncertainty does have an impact on morale, particularly when it's something like this, which not only, it's interesting, when you're in healthcare, you're usually worried about the needs of your patients and what's happening with them and what their risks are. Here was a situation where, in addition to worrying about our patients, we had to worry about ourselves and our staff. We were at personal risk as well from something that was invisible and frightening. So that was probably the biggest concern from a morale perspective for folks that I work with. I would honestly say for me, having the opportunity to kind of contribute and participate to the approach or the problem solving helped keep my morale very up and very positive and very optimistic. But when I saw, what folks were struggling with, whether they were those in the emergency room seeing these patients when they first presented, when they were in the hospital having to take care of the sickest of these patients, or even those that actually had to stop running their practices. So for like my specialty in plastic surgery, some of what we do is emergent, but a lot of it is elective, meaning doesn't need to be done now. We very early on stopped doing all that elective work. So we actually had a lot of physicians who were quite idle. And when you're idle, actually, sometimes your mind plays games on you and your morale can be more of a challenge. So those early days were difficult, but when we saw that our organizational response, And our civic response, particularly Gavin Newsom, and actually Santa Clara County, was very proactive and very aggressive at responding early. We were actually relatively quickly able to see that the worst case scenario was not playing out, that things were much better than everybody imagined they might be. So everybody's anxiety started coming down. And I think we hit a place in May where we kind of felt, okay, we can do this. This is manageable. We're not overwhelming the healthcare delivery system. We started talking about getting back to business as usual in some ways, meaning bringing patients in again for clinic visits, not just doing it all by video. Starting to resume some of our elective operations, doing so very differently, but in a very safe way. So people were starting to get a sense that, again, there was a light near the end, at the end of the tunnel. We could do a lot of our normal work while we still kept our focus on what was going on around us. And what has changed in the last few weeks is what all of you are aware of, and what you're hearing about is, we're seeing a pretty significant rise in the numbers of patients that are being diagnosed with COVID. And there are a number of reasons behind that we can certainly talk about. But that's what's, I think, creating more anxiety now. Is, okay, how is this going to play out? Are we going to be in a situation again where we have to stop doing surgery, where we have to stop seeing patients? Or are we in a position now where we can approach it differently, which actually I believe is the truth. So the morale, again, depends on the day and the time that you ask somebody and what they're doing and what their area of expertise is. But in general, I think people are confident that they can handle this. I think I personally, and I know many people I speak to, are very disturbed at what's happening in the community, that the reason we're seeing a lot of this surge is behavioral, which I completely understand. People are cooped up, they want to get out, it's summertime, but a lot of what we're seeing was a result of Memorial Day activities, then some of the protests. And now we've got July 4th on the horizon, and we're very worried that we're already seeing this surge, and July 4th could actually be a spark for a wildfire of corona if people really don't continue to do what they know they should do. The masking, the social distancing, all of that. Just because we've eased some things up doesn't mean we're back to normal. So that I think has created a lot of anxiety for folks here.
I see. So it's really, it's dynamic, right? Every day is different, and there's one day there's another thing, a new thing to be anxious about.
Yeah.
I see. And how has it been, you're wearing multiple hats, and you said that the practice has started to open back up for some elective procedures.
Right.
Have you seen, what is the patient behavior been like? Do you see people coming back in, or are people still just cooped up and delaying procedures?
Excellent question. When this all started, of course, we asked people to stay home, and we told people don't come in unless you absolutely need to. And people got that message loud and clear, because what we were actually seeing was some unanticipated negative consequences of that we weren't seeing heart attacks to the same level that we were. We weren't seeing strokes. And there was no reason for us to think that those weren't occurring. It's just that people weren't coming into the hospital. They got so afraid of coming into the hospital that they were getting adverse outcomes for other medical illnesses that weren't at all related to COVID. And that was really unfortunate and unforeseen, to be honest with you. And we tried to do a lot of messaging to counteract that, to try to get people to come in. But I can tell you, for the last 3 months, the usual demand that we saw for primary care visits, for specialty visits, for requests for surgery, all of that dramatically decreased, because people were thinking that the hospitals were overwhelmed by sick people, and that if they stepped foot through our doors, they were going to be at risk. And nothing could be further from the truth. I could tell you, we put so many things in place very, very quickly, particularly now that we have testing in place, and masking is now more universal. We can feel very confident that anybody who coming here for care will be safe. And the hospitals, we didn't turn into New York, we didn't turn into Italy. We weren't overwhelmed with sick patients lining the hallways. We never got to that point, fortunately. So we've been working on the messaging to get people back in, and it's starting to change. Actually, most of our specialty clinics in my medical center, I actually just reviewed this today, are anywhere between 80 to 120% of their baseline volume, meaning they're ramping up, and some of them are even busier, because in addition to seeing the level of patients they would normally see right now, they're also seeing the patients who waited. So some of our departments are extremely busy. On the surgery side, we've been ramping up for the last 6 weeks. With a deliberate plan to ramp up to about 100% right about now. And we're pretty close to our baseline volume of surgical procedures as well. But our plan is we need to get beyond that, because we had many thousands of patients who have postponed their surgery because of what was going on here. in reaching out to them to ask them to come in, most patients are willing, particularly some of our younger patients. Some of the older patients are wisely saying, you know, if my surgery is not critical, I'd prefer to wait for a while until we see how this plays out. And we actually used a data-driven approach to that. We actually looked at all of our patients who were awaiting surgery and looked at those that were highest priority from a surgical perspective. So we wanted to prioritize their clinical needs. Those that had the highest medical risk, so that would be a balancing measure, that if they really had a lot of medical risk and may have landed in the hospital, we certainly would want to not push them to the top of the list unless they were urgent. And then we actually even looked at their COVID risk, meaning, you know, if they were to get COVID, what was the likelihood of them having an adverse outcome? So we have very data-driven in my organization, which is very fortunate. So we're able to prioritize them. So when we reach out to patients, having that as a background, we can have really robust conversations about how to counsel them, you know, give them informed consent about whether or not they should be proceeding with surgery now. And we're filling up our schedules quite well. And
Wow.
I can confidently say we're doing it safely.
So it sounds like there was a prioritization exercise where you did
Yes.
the cost benefit analysis and you started
Yeah.
calling the patients down the
Yeah.
line.
Absolutely.
That's great.
Absolutely.
And what about other changes in behavior like telemedicine and
Yeah.
remote?
So on the outpatient side, you know, that was one of the huge, I guess, wins, if you will, of what we've been through. You know, in my organization, we've been trying to get particularly video visits off the ground for a long time. We already did a lot of secure messaging. We already did a lot of phone visits. So we did a lot of virtual care, but it was difficult to get video visits off the ground for a number of reasons. Patients weren't always excited about it. The clinicians weren't always excited about it. There were some technology barriers to make it that prevented it from being as seamless as we would like. So people would just default to the phone or to other things that were more comfortable. But once you took the office visit option off the table, all of a sudden people were motivated and inspired to try something new. And we got our video visits off the ground tremendously. I just heard today we now bypass over 1 million video visits since this started. So that has really allowed us to kind of still continue to provide care in a safe way, not bringing patients in unless they needed to, but still assessing what their needs were. And if it could be managed virtually, we would do that. If they needed to come in, we could be confident that that was the right thing that they needed for their care and bring them in safely. We dramatically decreased the foot traffic in our medical centers. We actually allowed a lot of our staff then to work from home because they could do video and phone visits from home. So it decongested the entire office building and hospital by having a lot of people be able to work from home and patients receive care from home. So our parking challenges, which we've been struggling with for years, all of a sudden disappeared. So there were some bright sides to that. And in one of my hats in my leadership role is performance improvement and innovation. And my message to the group is, you know, we need to hardwire for the future where video visits truly are the best model of care and not just go back to the way we did things before. You know, in my mind, the new normal for the future should not look like it did in the past. We need to leverage these opportunities that we learned, that we can do it and we can do it very quickly.
Don't let any crisis go to waste.
100% agree. I 100% agree.
So of the past quarter and a half, what has been your biggest surprise or learning?
A lot of them. I was thinking about this since we spoke about this, and one of the statements that I read on Nextdoor, which really spoke to me, is that, you know, a lot of people talk about, oh, we're all in the same boat, we're in this together, and what they said actually reframed that in a way that meant a lot more to me, particularly as we've seen how this has played out, is that we're actually all in the same storm, but we're not in the same boat, meaning that everybody is experiencing this quite differently. And that was surprising. I don't think everybody quite foresaw that. And some of that is related to the variable impact on different patient populations, whether it be the elderly, those that are in congregate settings, such as nursing facilities, assisted living facilities, prisons, those kind of places, you know, those are the ones that were severely impacted. And then secondly, the social disparity and inequity, if you will, minorities populations in particular, how they were so much more dramatically impacted than we were. And it just adds to the inequalities that we see in healthcare related to those socioeconomic dividers, if you will. So that brought that to the surface. And then when you layer that on top of all the, what I consider the other three major world-changing crises that we're going through right now, which is the economic fallout from the pandemic, the social unrest with George Floyd, and the response to the recognition of just how deeply ingrained our racism is in this country, and then the political division that we have in this country. Any one of those would be once in a lifetime events, and we have 4 of them happening at one time. So to try to navigate through this challenge with that as kind of the background and context, was also eye-opening. So for example, I think the protests contributed probably to some of the surge that we're seeing. But I think most of us would support the importance of those protests. So how do we balance the public health needs versus the right to protest, the societal needs, and then the economic needs? This is not public health at the expense of everything else. How do we balance the economic impact versus the public health needs? So in my mind, it's a recognition that we're not trying to eliminate infections. We're trying to tamp them down to a manageable level such that it doesn't overwhelm the healthcare delivery system, doesn't overwhelm the economy. And then the politicization of this was, I would say, shameful for this country. If you look at how other countries have responded to this, I would say frankly, I don't want to make this a political conversation necessarily, but I think at the national level, we made the mistake. Every step of the way, we made the wrong decision. I mean, it's really come to that. The flip side of that, though, is we've seen what strong leadership looks like. When you have somebody like Gavin Newsom or our leaders here in Santa Clara County take decisive action, despite that not having a kind of a clear national strategy, that to me, again, demonstrated the power of good leadership. So those things were kind of surprising. This is far more than just a public health crisis. It's far more than I alone or those of us on this call alone can do. It really is a collective responsibility. It's a shared responsibility. That it's not all a matter of just questioning what is our personal risk. We have to acknowledge that our behavior directly impacts the safety of others around us. And I think that's where we're losing sight of that with some of the behaviors we're seeing now. We're seeing some younger folks who are saying, I'm not too worried about, I'm not going to get that sick. I'll be able to survive this, but they're forgetting their responsibility to the society at large. So that was a lesson I think we're all learning the very hard way. But it is the reality that we need to kind of challenge. But there were some great things. I've seen how a big organization like mine can shift really quickly. And can, again, implement telehealth in a way overnight that we are now doing 1 million video visits in a short period of time, that we can ramp down our surgical cases overnight, but still provide care, and that we can come up with a strategic approach to ramping back up safely. We can get together to kind of figure out how to manage all the challenges with supply chain and PPE, with people's feeling of safety. All of these things were challenges that we hadn't had to tackle so head on, but we did so really, really well. Our planning around the surge, a potential surge, was incredible. We actually put the speed with which we were able to anticipate, what we would need at different levels of infection in the community. We moved pretty rapidly to design that. Fortunately, we didn't have to implement all of it, but that surge plan is now there on paper. So if this does get to levels where hospitalizations are going up, intensive care admissions are going up, we're ready. We're much more ready than we were 3 months ago. So we've done that foundational work. So I'm less worried about a big surge now than if we'd had the same experience 3 months ago, because of everything we've learned and everything we've put in place. So all of that, again, these are all the positive learnings. But I'm still, and people are flexible, people are resilient. We've dealt with one challenge after another here, like I said, all those other crises I mentioned that are also going on right now. Some of that has actually helped inspire people. The George Floyd protests, I think that really was a motivator for a lot of folks. We, like many other places, allowed folks to, actually was part of a kind of a demonstration, if you will, here at our medical center, to recognize many of our folks that work here are in minority groups, and they needed to be able to express themselves in that kind of a situation. So finding a way to do that and still have it be safe from a COVID perspective. And then the recognition of the power of community. I think it really touched everybody's hearts that works in healthcare. The amount of appreciation, gratitude, recognition, support, partnership that we've received from the community. I mean, that really has been truly inspiring, and that has kept people going when they were scared, when they were worried, when things got really busy, and will continue to. Like I said, that has been truly phenomenal. I think healthcare workers have always been appreciated, but oftentimes unsung heroes. And right now, I think they're feeling more like the sung heroes. People are really recognizing. And that's been beautiful.
That's good. Absolutely. Going back to your comment about resiliency and grit, I want to actually tie this back to your experience, your roots at MIT.
Uh-huh.
How do you think MIT has prepared you for this, I guess, once in a lifetime moment as a leader?
I love that question because I've thought a lot about this, and MIT has always been dear to my heart. I've been fortunate enough to be educated at a number of institutions and work with a number of institutions. And MIT always goes back to me as the one that is the purest in its approach to education and nurturing leaders, nurturing world-changing people. And what I've kind of identified, at least for me, that was the difference, is the approach to education. And it wasn't all about learning a lot of facts. It was, in my mind, it was all about more about principles. How do you approach a problem? So whether that a problem was during my education in biology or math or computer science, it's the fundamental principles of how you approach that. That's what I took away from MIT. I've forgotten a lot of my theoretical math. I wouldn't, because I've never had to use that. I had to remember some of my computer science because of my leadership work. It's actually become pertinent again. But it was more the principles have always served me well. And it actually is probably part of what led me to my plastic surgery career. Most people don't really recognize plastic surgery is actually a very broad spectrum, and it's really all about problem solving. Because much of what we do is reconstructive, which means if you're faced with a wound or a problem, they're not all the same. There's not a cookbook way of doing it, but there is a very fundamental approach from principles, basic principles of plastic surgery and problem solving and reconstruction. So you can tackle almost anything that comes your way in plastic surgery. And that's what my clinical career has been, is dealing with problems from head to toe on children, adults, elderly, men, women, any part of the body. All of those I've always felt confident being able to tackle because I was so grounded in principles. So MIT and then plastic surgery, and then part of my leadership work is on performance improvement and innovation, which is a similar thing. It's all about, regardless of the problem, how do you approach it in a manageable way? So that's how I approached this. When it came up, it never felt overwhelming to me in that regard. It really felt like, okay, I need to understand, you need to really understand the problem so you can start breaking it down into manageable pieces. But it served me well, and it created the excitement part of this work, which helped balance out the fear or the terror part of the work. So, but the MIT education it's truly unique it really is. It's truly unique.
And I feel like you've had a triply more intense experience at MIT than I did. So what do you think, what are the biggest obstacles you think we need to overcome right now? I know you touched on a little bit of just compliance earlier, being in it together, we're on different boats. What do you think is the biggest hurdle in our way right now as Americans?
I think it depends on, again, the framework you want to look at. I think as a nation, our biggest challenge is that we just don't have strong national leadership that is helping to frame the approach to this as well as the other challenges that I alluded to. I actually think that is our biggest struggle. Pushing it back on the states is just not the right approach, because as you've seen, the states all approach it very differently. The politicization is just a huge problem. People go to different sources for information, and the reliability of that information is widely variable. Some of it, whether you're right wing, left wing, there's good information and bad information out there. But the source of your information seems to be driving behavior in a way that is not aligned with science. So the fact that Fauci was kind of put to the back seat, the CDC and the World Health Organization were all kind of put to the back seat in our response to this, and it's all the political leaders that have been kind of the sources of information or response, is troubling, because this is shouldn't be a political problem. So that is at the national level, I think, our biggest concern. I think going right down to the individual level, I think the biggest challenge there is getting everybody to understand their individual responsibility for our successful response to this. If everybody feels it's not my problem, it's somebody else's problem, that I'm not at risk, it's only the people that are elderly or immunocompromised or have comorbidities, that it's their responsibility to sit at home and not interact with the world, that I can go about and do what I want, that is a false assumption. It's just a completely false assumption, because enough young, healthy people get sick will still overwhelm the hospitals and the intensive care units, and they still put those other folks at risk. So again, that I think at the individual level is truly my big concern. And then there's other challenges in between. We can talk about the availability of the N95 masks and the confusing messages around masks and social distancing, and the somewhat random strategies each state has had towards reopening. Some open bars early, some never open bars. It's really interesting to me that it doesn't seem, for many, there's not a lot of rational thinking behind it. It's more about who's putting pressure on them to do what. So I think lots of challenges there.
And do you think there's a example, like a good state? I know you had touched on Newsom in California. Yeah. Do you think if we had to pick a state, that California is a bit of a good
Early response, absolutely. California, I think, was the model of, in our country, of an effective early response, that they didn't wait till there were large numbers of cases before they recognized that this would quickly get out of control. So, Newsom stepping in, and actually Santa Clara County, even before Newsom did, stepping in to take decisive action was, I think, critical. And we saw what happened. We never saw, if you look at the early curve of our infections and hospitalizations, it was a small blip. I mean, we never got a surge. It was not even, it was a ripple, it wasn't a wave. So we had great early success. I think where we are now is, I'm not clear where this is going to play out. Right now, we're not outstripping healthcare resources, but the rate of increase right now is very troubling, very troubling. So if we don't do something again to bend that curve back down, we will not be the model. I think right now, if you look in our country of who is the model, I would go more towards the Northeast. The Northeast to Massachusetts, New York, New Jersey, who really had a horrible experience early on. They had a very different experience than we did in California, literally just by responding a week or two too late. They learned their lesson from that, and they've been much, much more deliberate in their reopening. And I think folks that lived there through that surge got the message more. Because one of the things that I think has been a problem for folks is, if you look around you, things don't look bad, right? You're not seeing sick people on the street, right? You're not seeing people lined up outside hospitals. Even if you go to the hospitals, they're not crazy busy. So it's very easy for people to be suspicious about the messaging. It's like, wait, you're telling me we've got this horrible pandemic going on, but meanwhile, we've got empty hospitals, we've got businesses closed. I don't know anybody that's had COVID, or I don't know anybody that's died from COVID. So I can see why people are saying, I don't know what to believe. If I look at my own personal experience, this doesn't seem real. If I read the news, it sounds like it's horrible. What is the real truth? So I can see why people are doing what they're doing. So if they don't trust the data, their behavior is going to follow from what they do trust, which is some folks telling them masks don't help, right? You can go and do what you want. That is all very, very worrisome to me, but I get it. It's human nature, and particularly when you get, here we live in California, it's beautiful weather year round. We got summertime here, people want to get out and play. I just don't think they recognize just how risky basic play can be.
I agree. And I think that it's a blessing that California wasn't a New York in the past quarter, but at the same time, that also means that we may not be taking it as seriously as New York, where everybody knows somebody who was impacted or may have passed away.
Absolutely. And my family's in Massachusetts, and they're, for the most part, have heard it loud and clear, and they're monitoring this all the time. They're being really cautious about what they do. And again, right now, we're not seeing, the Northeast is one of the few places where we're not seeing a rise in cases right now. Hopefully that won't change. Hopefully they'll stay there.
And speaking of data and news sources, I think, me included, a lot of us we're burned out on just the politicization and there's just a lot of bad news out there, right? When it rains, and with not only COVID, but with everything else that was going on with the protests and with race relations in this country, it's been really intense. Where do you recommend any news sources for us just to get factual data when it comes to the pandemic that doesn't have a political lens to it?
Yeah, I think there's a lot of data sources out there that I look at regularly. There's some of which you're familiar with. I'm so familiar with them, I don't actually remember their names, but I can pull them up. And Johns Hopkins was one of the early ones, kind of showing what was going on nationally as well as internationally. There's the trend report from the Institute of Healthcare Metrics that has done a lot of the projections that most people are familiar with, and they're constantly updating those projections. We're learning that projecting the behavior of this is really difficult. I think there's been some predictability there, but a lot of it has gone off the mark because there's just so much about this disease we don't fully understand. It is crystal clear, though, that United States is not on a good trajectory. So that is all good. So if you want to kind of look at data and projections, I think there are some great resources there. When it comes to kind of real-time information, that's a harder struggle. What I tend to do for myself, what works for me, is I tend to look at a number of different sources to try to get a sense of what people are hearing. So I'll even read Fox News stuff just to get a sense of what they're reporting, because it's always kind of fascinating to hear how CNN versus MSNBC versus Fox will report the same story with vastly different spins. So you have to use your critical judgment and be somewhat skeptical about things. The one particular caution I would make to folks is when you're reading about the latest and greatest on vaccines or treatments and all that, definitely be skeptical about that. I think what's great is there's a huge amount of research going on, probably at a pace that's unprecedented internationally. What that's leading to, though, is a rush to publish prematurely, meaning a lot of misinformation gets out there with the best of intentions, leading to certain actions, like we saw with hydroxychloroquine, for example, that then get proven not to be beneficial, but have caused harm in the meantime. So it's finding the right balance between, keeping people's hope up that there are things like remdesivir and dexamethasone that seem to have some promise. They're not miracle cures, but they seem to have some promise. But always look at it with a critical eye. Make sure that, yes, this is promising, but we still need more information to determine how it fits into our treatment armamentariums, if you will. Similarly for vaccines, we're all cautiously optimistic that vaccines will come sooner rather than later. But we got to keep in mind, what we have learned from history, right? We know a lot about infectious disease. We know a lot about infection control. We know a lot about epidemiology. We know a lot about vaccines. Reliable vaccines tend to take a long time to develop. So this push to say, oh, we're going to have a vaccine in the next few months, I think is not likely. I think we're going to, 2021 would even be ambitious, and it would certainly be wonderful. But even if we do get them, we are not going to know their reliability or safety as well as we normally would with vaccines. So that's going to be the challenge we have, is how do you deploy it? Who do you deploy it to? What are the risks that you're willing to take before wide-scale vaccination? The other thing we don't know is, what is people's immunity related to this? There's conflicting information about that. If you've had the disease, are immune, and if so, for how long? And that's an important piece of information for us to know even if a vaccine will work. If the disease doesn't make you immune, a vaccine may not make you immune. So we then need to think about, what treatment options we have. And I'm optimistic again, but I am also realistic, meaning, there is only one viral disease we've ever cured with medicine, and that's hepatitis C. We've eliminated many other viruses and controlled many other viruses, primarily through vaccination and through public health efforts when we see rises of things like SARS or MERS in the past, right? That those we've been able to kind of mitigate the impact of viruses in the past, but we don't cure them. So I hope that this will actually give us some momentum and energy to actually be able to start curing viral diseases. But all of these kind of uncertainties make me, I want people to realize that we are still in the very early stages of a very long road here. I think optimistically, we've only been through this, if you go back to December, we can say December, right? We're 6 months into this. 18 to 24 months, I think, is probably a minimum of our being through the acute phase of this. In the 1918 flu epidemic, it was not 1918, it was 1918 to 1920. It was a 2-year journey with multiple surges of different levels. And I think that's the kind of thing we need to be prepared for. And I'm not trying to make people anxious or pessimistic, but the more we're realistic about the challenges ahead of us, the more we will be able to do the right things to balance both the public health impact as well as the economic realities. We can't, there are public health consequences of a failing economy as well. So we need to, it's not all or one, we need to kind of find the right balance.
Right. And I think that's a very important point on the expectation setting, right? That this is at this point not only a marathon, it's just like a Ironman that we're trying
an ultra marathon, yeah.
We're trying to get through. And even with the vaccine, right? If you think about the rollout, right, there's a capacity limitation. So even if there is a vaccine, how do you roll that out to people? Because there's there's one vaccine constraint, right? It's not just everybody gets it, but you have to prioritize that in the grand scheme of all the vaccines that are given out.
Yeah.
Right?
And how do you do that in an equitable way? That's so, ideally you prioritize those most at risk, whether it be those who are medically most at risk, healthcare workers who are kind of at the front line. But I would even say, internationally, that's a big concern for me. This is, again, the rich-poor divide. I see that likely to play out with vaccines as well, that the countries that develop it will hoard it, the countries that can afford to pay huge amounts of money will get it, and those that are less fortunate and less able to do that will be left behind. And I think that's unfortunately likely to happen, and I think that would be tragic. So those are some of the challenges that we have, which is why I'm kind of glad the conversations about social disparities and inequities and racism, or all those things, are happening now. I actually hope that makes it harder for us to have that play out that way, that hopefully there will be more a drive towards a more equitable approach to how we disseminate treatments, how do we disseminate vaccines. And I just read an article today, unfortunately, which disturbed me, that the United States has bought up all of the supplies of remdesivir, which is like great if you're an American, not great if you're anywhere else in the world. So one of the few medicines that seem to have an impact, we're hoarding. That troubles me. It troubles me a lot. So.
Well, I hope that maybe Mark, maybe the algorithm that you develop for prioritizing which patients you call, maybe we can leverage some of that when it comes time to distributing the vaccines and treatments.
I hope so. Yeah.
Well, I want to switch gears a bit. What are glimmers of hope? What are reasons to be optimistic?
Yeah. I like I said at the beginning, I do remain optimistic, but I think optimism has to be in the context of realism, right? Blind optimism doesn't serve anybody well. But if you understand the realities of what you're facing, like we did back in March, when we kind of confronted head on and woke up to say, wow, this actually is real. This isn't going away. We can't bury our heads in the sand. Then you take appropriate action and you can have dramatic impact like we did in March. I'm confident we can do so again in California. I really do. I think if fortunately, Governor Newsom had another press conference, I guess, today, trying to again wake people up, slowing down the openings in some counties in the state. I haven't heard all the details, but I think that's the kind of thing that we need to kind of keep hammering away at, that we can't do this, but we have to do it together. So I still remain confident. I still remain hopeful. I am confident we can continue to provide healthcare for COVID as well as non-COVID diseases. We don't have to keep telling people don't come in. If you're having chest pain, please come in. If you're having symptoms of a stroke, please come in. If you're having knee pain and you need to have your knee x-rayed, please come in. We are here and available and willing to take care of you. I think our healthcare employees are becoming more confident that they can be safe while they're delivering care to these patients. I think even though there's so much we don't know about this disease, there's enough that we know that we are able to keep our employees and staff and clinicians and physicians and nurses safe. I think that's a huge step forward, which just makes me feel more confident that, again, it won't be back to what we had to do 3 months ago as far as just the total collapse of being able to provide healthcare. I think we'll find a way to continue muddling through, if you will. We just need to realize that this is going to be our new normal for quite a while and have that mindset. And in the context of that is, making sure people take care of themselves in the process, and not just take care of themselves from getting their needed healthcare, but making sure you are getting out and exercising, that even though you're socially distancing physically, don't become socially distant virtually. You still need to connect with people. And that, I think, we're seeing has devastating consequences for people who don't have social connections and outlets and are truly becoming isolated. The mental health burdens can be huge. So we do need to encourage people still to take care of themselves there, and find a purpose, find a way to contribute. So if you're not contributing in your usual way with your usual job because you're working from home or you're still not back to work, find other ways that make you feel like you have a sense of purpose. And I think, whether it's the protests that are going on, I think people are, again, they're attuned to what's going on in the world in ways that they had not been before. That gives me a lot of hope too, not just with COVID, but for how the world might look differently once we get through this. I'm hoping it's going to be a more equitable world. And one of my glimmers of hope is that we have an election coming, that, November is an opportunity for us to really say that we want to change. So whatever your leanings, just get out there and vote. I mean, I think that to me, I wish this pandemic didn't happen. I'm glad it happened in 2020, if it was going to happen at all, because we now have an opportunity to kind of say whether or not we think our leadership has served us well with all the crises that we're in, or if we need to change. Whereas if this had happened after the election, it could be a very different challenge ahead of us. So I think it all depends on whether you're glass half full, glass half empty, any certain issue. And I prefer to be a glass half full. I do feel like we can work our way through this. And I do think that in many ways we will be better for it. The tragic loss of life, though, of course, I would never say that is certainly not a cost any of us would want to incur for this. But given that we have to go through this, I do think that we can find a lot of positive things that can come from it.
Great, thank you. All right, and we are going to open up to audience questions. Although I'm gonna call Serena here because my swap card is not showing questions.
Okay.
I'm gonna call the
So,
Lifeline Serena.
Julia, do you want me to just read out the questions, or on the live discussion, can you see the questions at all on the website?
I can't see any questions. I'm on, oops, let's see here. Okay, I see. Is it in the chat box?
It's chat box, and there's also the other tab right next to it that says questions. And there's a few questions on there. So there's chat, question, polls. Do you see that?
I think I do. One of these questions is very, very long. So let's see. Okay. Question from Jan in the audience. What criteria should be used to reimpose restrictions, rate of transmission, hospital capacity, et cetera?
Yeah, I think it's a wonderful question, actually. You know, what we look at, what we're trying to do is model if we can identify early warning signals. So what you don't want to wait is till the last minute when your ICUs are overwhelmed and you've got no ventilators, and you know that is far too late. What we've learned over the experience of this is we actually do have some of those early indicators, at least in my organization. One of those is actually the number of calls to our call center. So one of the mechanisms that our patients have for accessing care is they call our ambulatory call center to get advice, and they can then help set them up with appointments if that's what's appropriate and do all of that. And we have huge amounts of data that flow from that, one of which is the calls that are coming in related to respiratory symptoms. And when we looked back at what happened in before March, we actually saw a dramatic rise in the number of calls we were getting with those kind of complaints. Even though it was flu season, it was higher than what we typically saw for flu season. So when we looked back, we were actually able to see that was actually an early warning sign, because what we saw 2 weeks later is that's when our hospitalizations started going up and our intensive care unit admissions started going up. So in the absence of testing, that has been really served us well. When we start seeing more patients calling with those kind of symptoms and complaints, that lets us know that something more is coming. And that's where we are right now. I can tell you throughout Northern California, that's exactly where we are right now. Mm-hmm. The number of calls we're getting for respiratory symptoms are rising exponentially right now. And we're starting to see that now translate into hospitalizations, particularly like in Modesto, Oakland, South Sacramento, those areas. They're the ones that are currently seeing the surges, if you will, whereas we were one of the early ones. So that's the other thing we've learned, is that there's geographic asynchrony, if you will. So in March, it was the Santa Clara County that really took the hit. But if you looked around the rest of the Bay Area, they never really got much of a volume of COVID until very recently. And then we started seeing East Bay and the Central Valley and North Valley starting to be impacted, while we at the Santa Clara County have actually been okay. But we're now starting to see those upticks in other areas too. So call volumes for that is one of the things that we're looking. The hospitalizations are unique this time. So in the first wave, most of the people that came in were elderly, very sick. Many of them ended up in the intensive care unit and on ventilators. We're not seeing that right now. We actually, in my medical center, we had 6 admissions over the weekend and 6 the weekend before because of outbreaks in assisted living facilities and some in younger folks, but none of them are in the intensive care unit. They're all just in the regular, what we call med surge beds. So the pattern is behaving differently. So that's a long way to kind of say we're kind of keeping an eye on all of those things. And the main focus is to make sure that we don't put ourselves in a situation where we're going to outstrip the hospital capacity to provide care, not just to COVID patients, but to everybody else who needs care. And at this point, we don't feel like we're anywhere near that, at least in my organization. The testing numbers have been very confusing for a lot of people to understand, because Republicans dismiss it by saying, oh, you're finding more cases because you're doing more testing. And that actually is partially true, right? When we first started testing had such limited availability that we had to really severely constrain who we tested. So we really only tested those who were severely symptomatic or that we really were highly suspicious they had COVID. So we weren't doing a lot of tests, and we were testing only those that were sick. So those that were asymptomatic, those that were minimally asymptomatic, or even those that were symptomatic but stable, oftentimes didn't get tested. We told them, just presume you have COVID, go home and treat yourself as if you do have COVID. We're in a very different place now. We have Fortunately, a lot more testing. So we're doing a lot of testing in what we call surveillance, meaning people who are asymptomatic but meet other criteria for testing. And actually in my county, anybody who wants testing can get tested. So we're testing a lot of people who don't have symptoms. And when you track that and do that, you're going to capture more of these asymptomatic folks that we weren't seeing today. So we will look like we're seeing an increase in case volume because we're identifying folks that we weren't identifying before. So that is when you want to frame it that way, that is part of the truth. But what's different though is we are seeing increasing hospitalizations. We're seeing, if you do increased testing, but you don't have increased community spread, you would actually expect the percentage of tests that are positive to go down over time, right? So if there's very little virus in the community and it's not going up, then as you're doing more testing, you should get more and more negatives and fewer positives relative. We're not seeing that. We're actually seeing the percentage of positive tests going up. So that is a sign that there definitely is an increase in spread. It's not just because we're doing more testing. So we are identifying more of them, but there is definitely an increase in spread that's going out there. So that's what we're monitoring really, really carefully. But where that so that testing positivity will then down the line translate into more hospitalizations, which tends to then translate into more intensive care unit need. What I would say that's different now that may limit the need to kind of shut down is we have a surge plan in place too. So even if we do get busier, we already know how we will expand intensive care unit and med surge bed capacity. But we'll have plenty of lead time to say we need to start backing off. Now, at the same time, there is what I would say the political need to do it. So that's the medical need to do it. There's also the political need to do it, which is what I think Gavin Newsom has been really quite good at, is recognizing that there's a responsibility to kind of call people out for their behavior. That what we're seeing now, we don't want to wait till it gets worse, that we need to take action now to change that. So even though you may or may get away with it, it's really a matter of enforcing the discipline that I've been kind of mentioning throughout my comments, the personal discipline that we each need to have so that we get to the point where wearing a mask is as second nature as leaving, you don't leave your house without your mask, just like you wouldn't leave without your phone, your keys, or your wallet. They're the kind of things that if you don't have them, something's missing. That's where we need to get to with masking and social distancing, that it becomes second nature. It's just the way that we interact for the foreseeable future. That a mask is something you wear unless there's a good reason not to wear it. It's not that, oh, do I need to wear it? Or, you go without it until you have to wear it. In my mind, it should be something, the default position is you wear a mask. And the default position is you stay 6 feet away from people, unless you're absolutely confident that it's safe. That's the kind of mentality that we need to get to. And that, to me, is actually the biggest driver for why we need to slow down the opening of the economy and businesses. Because if people will do that, we can actually much more confidently and safely do a lot of the things that people are really anxious to do. But if they don't do that, then you see the kind of explosions that we've been seeing. So long answer to a long question. So, but there's no single one thing, but we need to look at the entire pattern of what's happening and look at it in a sub-regional area, not look at the state as a whole, but look at different counties or sub-counties to see where you need to take action. And look at places like San Quentin and nursing facilities and assisted living facilities where you get really major outbreaks. We should be doing a better job in places like that too. Those are driving up the numbers, and those are very vulnerable populations.
I see. So what I'm hearing is it's not just these three factors, but it's holistic. Right? And then if we see places like South Korea, where life is slowly going back to normal, schools are opening, the mask compliance and the social distancing compliance is much higher than it is here.
Yes. Yeah. And that's really a necessary piece for us to really reopen with any kind of safety at all.
Mm-hmm. And I have a question around the actual science of the virus. So there's been talk about and research about the mutation, right? That what was spreading in Asia is different from what was spreading in Europe, which then entered New York, and what's in the US. Any thoughts or any recent learnings on that?
Yeah, I think what we know, viruses mutate, right? That's why the flu virus, for example, that's why we have a different vaccine every year, because we know the flu virus is going to mutate every year, and we don't know to what extent, and we have to kind of try to predict it. So everybody expected the coronavirus to mutate. The other coronaviruses, like the ones that cause the common cold, they mutate as well, right? They you can get a cold over and over and over again. So that created concerns. What appeared early on is that it seemed to be a much more stable virus than people were worried about, which is a good thing. And I think that's still true. The mutation that you just mentioned, though, did seem to, for whatever reason, at least in the United States, seem to become the prominent one. And it's not completely clear why that is. Why did that one become the dominant virus? And we also don't know what the impact of that is. Does that mean there's questions about whether that makes it easier to spread? Does it increase the asymptomatic spread? It's not clear. None of that is clear. The challenge with mutations, though, is it can make development of vaccines more difficult, as we've seen with the flu virus. So if the coronavirus were to change rapidly and significantly, the vaccine that you develop this year may not have very long-term benefit. So I think it's still early in the journey. We still only have 6 months experience with this virus and how it's going to behave over time. But it's something that we need to be aware of and be mindful of as we're looking at developing vaccines and how this might behave over time.
I see. And then earlier you had mentioned how the calling in for the respiratory symptoms is often a harbinger for what's to come with hospitalizations. What is typically that lag time before one starts exhibiting their first symptom to getting so bad that they have to check in to an ICU?
Yeah, it's interesting. We're learning more about that. The incubation period, if you will, is anywhere between 3 to 14 days, and the viral load, meaning the amount of virus that's in the throat, for example, is usually peaks in most people just before they get symptoms. So that's why the concern around asymptomatic spread, for example, is that they may be spreading that at that point. So that's the concern. We still don't know how much they spread it when they're asymptomatic, because they may not be doing some things like coughing when you get symptomatic, which certainly coughing, sneezing, all those things definitely increase spread. But so once they get symptoms, that's usually when they start calling for advice, for care. And most people have this kind of golden period, if you will, where the symptoms are manageable and tolerable. And for the first week or so, most people do well. Most people who do poorly, it's usually in the second week of illness. So we generally see up to about a 2-week delay between the time people are calling before we see significant increases in emergency room visits and hospitalizations.
And it seems like there's such a wide variance. I know that it's still early days, but it seems like some people just get the sniffles and then they get better. And then obviously the other end of the spectrum, where we even see young people passing away.
Yeah.
Have there been any learnings about like the comorbidities or any of the correlations to other pre-existing conditions?
Yeah, there absolutely is, and the comorbidity risk is independent of age. Meaning, if you're obese and you have hypertension, diabetes, kidney disease, those kind of things, your risks go up significantly. Age is in itself a risk factor. When we look at least the early data, anybody over 60 is at significantly greater risk, whether or not you have comorbidities. If you have even one comorbidity from age 40 on up, you're at significantly increased risk. So when I talked about the risk stratification that I talked about for our surgical patients, that's one of the things that we identified and looked at. And so you really got to be below 40 with no comorbidities to be considered, relatively low risk, I would say. But having said that, this is not a pretty disease. This is not a disease anybody should be rushing out to get or minimizing. There's a lot we still don't know. We don't know, like I said, why do some people get it much worse than others? Why do some people lose limbs? Why do some people have strokes? We've had young people who never had respiratory symptoms have strokes because of what seems to be happening with the clotting mechanism. So, this is not just a respiratory illness. It seems to get into the blood vessels and affect clotting. So some of the complications related to, again, strokes, pulmonary emboli, some of the breathing problems are felt to be related more to that in some patients than it is to actually the direct involvement of the lungs and airways. So there's a lot we just do not know, and we don't know the long-term consequences of this. Some viruses live in us forever. Chickenpox, the hepatitis viruses. So it's not unheard of for viruses to, even once you get past the acute phase, to not necessarily clear it. And from what I'm hearing, we hear anecdotal stories of some people who are sick months later. So there are some people who just may not be able to clear the acute phase of the virus. So this is the stuff, we're so early on in this. Again, it is a novel coronavirus. It's called novel for that reason. We just don't know the details of how this is going to behave, which is why, again, I'm advocating and pushing so hard every time I can for people to do all the things they can to keep themselves and others safe. Because by doing so, it's not just not overwhelming the healthcare delivery system. It gives us time to learn more about this, to learn better how to treat it, to learn how to prevent it, to learn how to protect people from what could be significant long-term consequences. So that's my plea to everybody. It's not a pretty disease.
Mm-hmm. So no one should be complacent. There are
No one
too
should be
many
complacent.
unknowns we should not be
Yeah,
rushing to
right.
try to get it or diminishing the risks in any
No,
way.
no. And we don't even know if you get it, if it's going to keep you immune. So you may put yourself through that
Right,
for not, you could still get it again. So we don't know
right.
that.
And what about learnings from, there's just been some very strange impacts it's had on children. It clearly impacts children differently. Is there any further evidence or data on this?
Yeah, I think, it's behaving again, it's again in another immune mediated response to this infection. I don't think we've had enough cases to really understand fully why this virus is triggering that in those patients, any more than we understand why the virus triggers that cytokine storm in some patients and not in others. There is probably some genetic predisposition to it, because it's certainly not pervasive. It's not something that happens broadly. And in kids, it's still a fairly rare event, but it's a very disturbing event, of course. And the same thing with the cytokine storm. There's been everybody's looking at everything, right? They're looking at blood types. There seems to be variation in the severity of disease based on blood type, where folks with blood type O seem to be less likely to get severe disease than those with other blood types. How meaningful is that? Is that going to translate into a different approach to treating it or managing it? Hard to say yet. Again, lots to learn, lots to learn.
Great. All right, we have a few minutes remaining. I guess what words do you leave with us, and ways that we, for those who are not in the healthcare community, how we can continue to make the most impact that we can and play our part?
I think individual behavior, modeling great behavior, and being a voice for reason. I've always looked towards MIT folks and MIT graduates for that ability to kind of take things and put a rational framework around it. And I think that it is so sorely needed right now, because it's become so irrational and visceral and emotional for many people. I think helping people kind of put it in terms that they understand about what they can do, because I think having a sense of control is really important when you're going through the kind of crises that we're going through right now. That loss of autonomy, loss of sense of control can be really upsetting and disturbing. So there are things that individuals can do to have an impact here. And if all the individuals do that, then collectively we have a huge impact. So that's my plea is practice those behaviors, model those behaviors, and then again, be a plea for reason. When people are being irrational, try to engage them to see if you can help them better understand what this is all about, because it is, I get it, it's confusing and rapidly changing.
Wonderful. Well, thank you so much, Dr. DuLong. This has been a delight re-engaging, and hope that you are also staying well and taking care of yourself, because we certainly need our healthcare workers now more than ever. Thank
you so much, Julia. I really, really appreciate it. Thank you for this opportunity.
All right. Thank you so much, everybody.